So Karl, tell me more about the study that you're presenting tomorrow.
Yeah, so about this study. So, recently Pembrolizumab got approved as an adjuvant IO. It's the first adjuvant IO approved with an OS benefit after 50 years of trial. And then a lot of questions arise about, so when this patient recur on or just after adjuvant IO, what do we give this patient? Yeah.
Wonderful. So it seems like we looked at the outcomes of the patients who received systemic therapy after adjuvant immunotherapy. What do you think were the key results of the study?
Yeah, we had like 2-3 highlights of the study which were very interesting. So the first one, it was very interesting that we found that patients with early recurrence had higher bone metastasis rates compared to patients who recurred in later stages. This is the first finding. The second finding is also an interesting finding. We found that patients were benefiting from either VEGF therapy or also immunotherapy-based regimens. So we observed, it's still early to draw a conclusion, but we observed good radiographic response in both regimens. The final one is that IMDC risk factor, risk group, actually is still a good prognosis even after receiving adjuvant IO, and it can also predict the prognosis of these patients.
Wonderful. And can you tell us about where did these patients come from and which centers, and is this a international study?
That's a great question. So this was a huge effort where we contacted more than 30 institutions across the world, like 13 or 14 countries. It was also a joint effort between multidisciplinary approach, like between urologists and oncologists. So it took a lot of effort to gather this cohort because it's still Pembrolizumab got recently approved. It's been just like maybe 4 or 5, a little bit more years that it's been given. To gather this cohort, we had to do to get a multi-center approach and get there.
Wonderful. Yeah. And in terms of, let's say patients come into the clinic and we want to counsel them on adjuvant immunotherapy and risk of subsequent immunotherapy, how would you approach that?
Yeah, I think that's a tricky question, but mainly I think the main point, patients should be aware of the benefit and risk of adjuvant IO. So we have to be frank with our patients. There is some immune-related adverse event, but also the positive thing is that we can cure this patient. We can boost the curative potential of the surgery with this adjuvant IO. So we have to present for the patient that this is an option, it's available, and present both sides of taking this approach.
Wonderful. And it was interesting, this result that patients who had bony metastases were more to have recurred earlier. Do we think that these patients might have had bony metastases before they started adjuvant immunotherapy and that was missed on imaging?
I mean, that's a hypothesis that is very relevant, and this, by the way, highlights the need of maybe better biomarkers to predict, to maybe better imaging also tools to try to detect occult metastasis, they could be bony and they didn't detect it at the start, like you mentioned, but also the need of any biomarker that can predict recurrence in this patient. Liquid biopsy is arising, circulating tumor DNA, but also maybe AI and advanced imaging tools that are also gaining ground and gaining traction in the field.
Wonderful. If you would summarize take-home messages for any clinician seeing your poster, what would be your 2 take-home messages?
Yeah, I would say we can still look at the IMDC risk group score, at least as a prognostic factor for our patient, I would say also it's still an early, a small cohort. It was very hard to get these numbers from multiple countries, but it should call for maybe more clinical trials to try to answer this question and get more robust conclusions.